Okay, good morning and welcome to the Davies Use Case webinar being presented by Banner Health on bundle compliance for blood product. This is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety here at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations and clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speaker for today's webinar, Jill Howard, who's the Associate Vice President for Quality Design and Reliability. Jill, I will turn the presentation over to you, and you can begin when you're ready.
All right. Thank you, Mr. Simmons. Really privileged to be able to share Banner's story and how we do bundle compliance, and particularly around our blood product utilization project. I thought what would be helpful is to give all of you a little bit of an orientation to Banner Health, as it will help to understand how we approach some of our clinical reliability and quality across our organization. Just to take a glance here at Banner, you'll see we're across 6 different states here, primarily in the Southwest. Includes 28 acute care hospitals, medical groups, home care and hospice, surgery, urgent care. As you would see, pretty much most of the different healthcare delivery products Banner has as part of its product of services. You'll see that in terms of our size of our organization, we're $7.6 billion in revenue in 2016. So it just gives you a sense of how large our organization is. Our mission, which is important to know, centers around our consumer, who we call Sophia in the center here. But you'll see that part of our mission here is making healthcare easier so life can be better, making sure that we're perfecting that customer experience, engaging, inspiring the people around us, reaching our impact, and helping our customers be their healthiest. One of the things that makes Banner a little bit unique for the size of the organization is our operating model, and I take note in that because it does have a big influence on how we get things done in our organization. And probably the biggest piece here is that we have one board of directors. We have a centralized management structure with centralized corporate functions. That allows us to really do things in a more standardized approach across the organization. We have some things I'll share with you around how we are designed to achieve results and improve upon clinical quality and care. And again, we've got through our strategic initiatives and clinical initiatives, that's how we achieve alignment out across such a large organization, and that really comes down through the organization from that central model. So let's talk about a little bit more detail of how do we get quality of care done. This is a slide to say quite a cast of characters around a table. When we think about getting research out into practice. Notoriously, this takes healthcare about 17 years. And back really in about 2009, Banner really took a step backwards and said, geez, how do we really organize ourselves across such a large organization and primarily comprised of independent practitioners? How do we drive clinical quality and reliability across such a large organization? And we said, you know, it really has to depend on our clinicians. They're really the ones who need to set what the care practice needs to be, and then how do we orchestrate that, implement that across the organization. So a secret to our success, we like to say part of our secret sauce is we brought together early on a group, and we started with some cardiologists. So you can imagine we brought a group of independent cardiologists, all from different practice groups, around the table and basically posed that question of how do we get all of you to work together, and how do we make sure that we're providing the best and latest research care across our organization. And so that really took us to, you know, really saying how do we then drive reliability at the highest levels in our organization. And a slide here that just kind of makes you pause and think about reliability, you know, just 10 to the 1 about preventing failure. Certainly standardization gets you there, checklists, all important things to do. How we identify and mitigate failure, again, eliminating workarounds, doing more continual improvement gets you about 10 to the 2 reliability. But then 10 to the 3 is really when you say, hey, I've got to really do this and redesign it all over again. So, so we said, geez, you know, when you look at healthcare and you reflect back on the aerospace industry, which really was the leaders in reliability, and you said, is 99% good enough? And as you can see here from the slide, if we were at 99.9%, which is 10 to the minus 3, you would see, gosh, we'd have all of these things, you know, 2 unsafe plane landings, lost mail, bank errors going on, and so that's really the preface that helped us start to say, how do we orchestrate our organization for designing clinical reliability? So as we say here, our approach is based on ensuring that reliability is across all of our clinical systems and processes. So 3 major components is defining clinical standards and designing processes and implementing those across our organization. Monitoring and assessing, obviously, you know, you can't improve what you can't measure, so making sure that we can track our performance and continually improve. And then certainly addressing areas for opportunities for further improvement. So in a summary, our approach is really how do we leverage the expertise of our clinicians across the organization, and that's part of our secret. Using that operating model for our organization, using that deep talent, developing physician leaders in our organization. Obviously, it takes a village to do improvement, as we like to say, and so it requires a multidisciplinary approach. Important, too, that we use science-based principles to improvement. And you know, always thinking about simplifying and not adding complexity. And importantly is that we have a consistent approach to improvement. So let me talk a little bit more about this structure is what we call our clinical consensus group. So this is where we bring, like we said, like the cardiologist sitting around the table, we bring these clinicians formally together in what we call clinical consensus groups. And today we have 22 of these groups, And their primary role is to define the expected practices for Banner and oversee that work of designing and implementing those, as well as monitoring that performance of those practices over time. And also just to take note of this slide, as you'll see some resources that circle around these clinical consensus groups. What's important here is that these are resources that are allocated to supporting this work across our organization, whether that's program management. We have process engineering who do a lot of the design work, the operational design, our informatics group, which is obviously important for designing our interface between our work and our electronic medical record. And we've got quality folks who are on the ground, if you will, out in the operating entities, ensuring improvements occurring. You've got to have analytic folks to help with the data and get data out there in front of everyone, as well as clinical educators who help in making sure that we're providing education around our practices. And then the second half to the structure for Banner is a standard methodology that we use to do improvement. And we fondly call this across the organization DDI, which stands for Define, Design, and Implement. And as you'll see, the define is really where we look at the research, look at what are opportunities out there for improvement and doing things differently. We then go to design, which is about designing requirements and designing the operational process flow, developing the informatics pieces and any other requirements of that design. And then the output of that is an implementation toolkit that then gets handed over to facility or entity leads in our operations, whose role then is to operationalize that in their respective facility. And of course, we have implementation status meetings and monitoring progress, and then eventually then we turn that over then to operations for ongoing monitoring and improvement. Here on this next slide, you'll just see a spattering of some of our clinical practices. I think today we're at about 260 of those practices, but this just gives you a sense of some of those that we have in our organization and the work across our clinical consensus group. So with that, I'd like to take this opportunity to go into one of our projects that we did in our organization around blood product utilization. Thank you. Thank you for this opportunity to share our blood product utilization project. Again, just to remind you, my name is Jill Howard. I'm the Associate Vice President for Quality, Design, and Reliability for Banner Health. And as we get started here, I'd like to just say one word is that this project was led by one of our chief medical officers who is now retired, so I feel like I'm standing in for him. But I can't overemphasize the importance of having strong, passionate physician leaders. And as I move forward in this project, this will become more obvious to you. So let's just kind of step back, and again, we really looked at this project back in 2012, and so as we do, we look at what's the research out there, what's the industry telling us, and as we see that several efforts at that time were underway, like the 100,000 Lives campaign, and certainly really a focus on patient safety. And so when we looked at this, we said, geez, there's a significant amount of risk, if you will, with blood product utilization administration, ranging all the way from, fever to, mortality. And so you know, an important thing that we have to realize that it's just not, it's inherent in causing risk as well. When we dived into this further, you know, additional research indicated that approximately 30% of red blood cells, 25% of platelets, and 60% of fresh frozen plasma transfusions are deemed unnecessary. And if we think more specifically about red blood cell transfusions, this has been basically a historically hardwired rule. So clinicians really, you know, they don't even think twice about this historically. And they used what they called the 10-30 rule, which is if the hemoglobin was below 10 and the hematocrit was below 30, you would transfuse. And it was kind of like became a no-brainer, if you will, for physicians. So despite being classified as a drug, you know, usage really was driven more by culture than by evidence. And even when we had the American Association of Blood Banks recommending that you should really only transfuse when the hemoglobin's less than 7. And not surprising that reducing variation, in this case blood product transfusions, would actually result in more improved surgical outcomes. So I guess the more variability, as I know I'm probably preaching to the choir around variability, that the more variability you have, then the more you probably have differences in clinical outcomes. So again, something that really helped drive us to focus on this project. So in 2012, we created a clinical strategic initiative to reduce unnecessary blood transfusions, realizing that unnecessary transfusions create the potential for harm, patient harm, and waste. And just to share the cost of red blood cells, and you'll see just for like a unit of cells, the cost really goes beyond just that base unit for that product. The costs really exceed, you know, much higher when you layer in the administrative and management of those products. So as we started to look at, again, our initial work, we realized that this wasn't just about minimizing unnecessary blood transfusions, but it was really about blood management. And then we needed to consider the components of what comprise blood management. And as you'll read here, that you need to address really 4 main factors, which is the need to address preoperative anemia and help to optimize erythropoiesis. Of course, you need to make sure that we're preventing and controlling blood loss. Obviously, we didn't focus our efforts on that, but that's certainly part of a blood conservation focus, that you need to look at what are employing blood conservation methods, and then focus on evidence-based use of blood products and minimize its inappropriate use. So where were we relative to this back at this point in time? And you'll note that our overall average for blood transfusions, and we started to look at just elective joint replacements because that's where we found we had the greatest opportunity for blood transfusions, and that we were at 20 overall across our organization at the time, 20.4%, and which is just a hair better than the what we used Premier as our benchmarking, which was at 21.3. While some might say, hey, okay, you're better than the average, it just tells us that still most of us are not doing probably as good of a job as we could. And then we really need to do better as an organization and even as an industry to really improve the use of blood products. So you'll see that we set a pretty conservative stretch target of 19.8%, realizing that we had a lot of change to do, and that was the change of addressing the hardwired practice of how clinicians think about blood transfusions. So again, we started to approach our design and implementation and utilized our CCG process to do that. In this case, since we were focusing on elective joint replacements, we took this through our orthopedic CCG, who then defined that clinical expected practice. And so we then also organized the resources around that to begin the design of that. And again, to take you back to that, we use our DDI process to design that. Now, when you look at our main key elements of our design were around these three areas, which was, again, thinking about the blood management process. So the first thing that we did is addressed autologous donations. Back at that time, again, we're talking now close to 15, 16 years ago, that autologous donation was a common thing that was done. And when you looked at the literature and research here, that generally that actually made folks a little bit more open to being more anemic preoperatively. And also we noticed that if you allow enough time for them to build their system back up, then a lot of times that unit would be close to expiration. So, and of course, along with all the other risks that come with being administered a product, we said we need to discontinue that practice. The other key design element was this restrictive approach to transfusion, and that was we were making a stance that transfusions, we should not be transfusing for anyone who's got a hemoglobin 7 or greater. So only to transfuse when it's less than 7. And of course, there's exceptions to that. It's assuming they're hemodynamically stable. And there's a few other exceptions that I'll make note of later in the presentation. And the last key design element here was making sure that we're doing appropriate anemia screening preoperatively, and that if patients had some anemic issues, that we would then do some interventions such as iron and EPO-10 to boost their erythropoiesis. So here's where I come back to the beginning of my presentation when I talk about the strength of having a physician champion. Changing the culture of that 1030 rule was not going to be an easy task, and we knew that was going to be our primary barrier. So we really had to address this surge in habit of transfusing based on that old rule. We knew we had to build in some accountability to that, as well as addressing the autologous unit. So we had our physician lead here did a lot of work of going around to all the different physician groups. We go to our other CCGs, to our medical staff, and really had to do a lot of education and bringing research forward around unnecessary transfusions, and that it was okay to not transfuse when the hemoglobin was just above 7. So we used peer comparison reports that we looked at utilization across our different clinicians, and that's always helpful for physicians to see how they compare to others. Our physician lead also did a lot of work as saying, when we had physicians saying, yeah, but my outcomes are better, he would challenge them on that and sit down and go through their information and really disprove that their outcomes really were not better related to transfusing. We also had other processes in place that our expected clinical practices then become, they're expected. And if providers are not following those practices, those can be subject to peer review, and they're part of our quality indicators. And then around autologous transfusion, we then basically, put a policy out there that we would discontinue that, and we actually worked with our associated blood bank programs to discontinue that service. Okay. As far as design, although this practice did take a lot of time by our physician leaders to meet with surgeons and go over the practice with them, we realized education alone will not ensure a sustained and reliable change. As we all know, that you've got to do more than just educate. So part of this process design included changes in pre-op testing for anemia on the ambulatory side, and using standard order sets to do that, the use of hemoglobin boosting interventions as appropriate. And then the main change that really helped drive the consistency in the practice was the design of a transfusion alert in our EMR at the time of order. So this is our details of that alert, and you can see it's for adult patients, and it fires on 2 points. If the hemoglobin that's been done in the last 24 hours is greater than equal to 7, it will fire, or if there's been no hemoglobin done within the last 24 hours, it will fire. You'll see here under the alert options that some of the other criteria which they can indicate that would be exceptions to that. At Banner, we do not ever force an alert that force the action. A provider always has the ability to override the alert. Then we ask for them to put in the reason, and we have drop-down reasons that we ask them to select so we understand why they're not following that practice. But we always allow them to override as sometimes clinical conditions, you can't address every scenario. That always allows them the ability to do that. Here is the first alert. You'll see on the right of the screen here, this is actually what they see that pops up when the hemoglobin is greater than 7 and they've ordered blood. It basically suggests to them that this is not necessary, and if they've got criteria why they think this should be done, they can actually click down below that what's that criteria that the reason why they are not they can't follow that practice. And then the other convenient thing here is that they can also click here and actually it can immediately cancel the order. So it's making that convenient for them. They don't have to go out and go into actually the order area to do that. And then likewise, here's the other alert when there's no hemoglobin on file and suggesting that they do a hemoglobin before they transfuse. And again, they have the opportunity to then why that they feel they need to continue moving forward with the transfusion. As I stated, it's hard to change a very hardwired practice of a culture of transfusing blood. So, you've got to be able to monitor this, particularly early on. That helps you identify the physicians where you're seeing them fall out of that criteria. And this became a list for our chief medical officers at our respective operating entities to go and follow up with those respective surgeons to understand and again help them understand the practice and understand the reasons why they may not be following the practice. So after all that, where did we get to? So as you can see, we're way too conservative on our target in that first year, and got to, at the end of the first year, you know, way down to really the 8% mark in that first year towards the end of 2013. And then you can see over the years, then we're basically at a very negligible level of 0.2%. What's important here that I really want to point out is the nature of this curve. And this is what I'd say a prime example of where you're taking a very hardwired practice and trying to change physician pattern after that. And so this is what we call where you have your early adopters, which is really, you see in your first year, you kind of got, you know, the folks that, hey, well, I kind of get it, but I'm going to wait and see a little bit. Those are your mid adopters. And then you got those, some that just hold out until, you know, they're really sure this is okay to do, in what you call your late adopters. And then once we did that, you know, it took our performance right down to, I said, a negligible level, and we've been able to sustain that over time. And now we can say, hey, I think we've got now our hardwired practice. The next thing saying, well, what about the alerts? You know, are the alerts still firing like crazy and they're just having to comply? No, the alert pattern as well actually followed a similar curve. You know, in 2013, we created that alert, and so you're going to see then the data go up from there. And you know, you'll see that same kind of early adopter, late adopters there, with the exception of we did have a blip in 2015, and we brought on a couple of new facilities into the Banner family at that point in time, and so that was really about learning that transfusion practice. So and then of course once that was learned, then you know went right back down to where we have very, very few alerts firing on a quarterly basis. I actually looked at just this last quarter, and we only had 13 firings of that alert. So it gives you a sense of across a large organization, only 13 in a quarter. So really the power of that alert in reinforcing the practice. So let me just kind of take a minute here to summarize, you know, all the pieces that we did here that got to what I'd say a really reliable and sustained practice in our organization, and that stakeholder engagement, you know, having engaged physicians, a strong physician leader, can't overemphasize that importance. The fact that we discontinued the autologous blood donation program, we really put a hard practice in place to say, nope, can't transfuse if the hemoglobin's greater than 7. We made sure that we're screening for any anemic or conditions that put folks to at risk for anemia and boost some clinical interventions around that. You know, we put the alert in place. And one other thing here that I didn't mention early on is we actually found we had to do a little bit of patient education and setting expectations of their surgical experience. So we were actually quite surprised that we had patients and families saying, well, are they going to get a blood transfusion? And thinking that their loved one or they should be transfused. So we found that we had to do some patient education, put that in place around that program. So that's the summary of our great story here of how we take many components and package those together, leveraging the expertise of our organization, having a structure and standard processes, engaged providers, and a team of great folks who can put all the pieces together and then sustain improvement over time. I just want to thank you all for your time today, and thank you for this opportunity.
Well, thank you, Jill. for that presentation, and thank you for joining us for this webinar today. I want to also remind folks where to go find other quality Davies use cases. That information can be found on the HIMSS Davies website at hims.org/Davies. You can find recordings from other Davies use cases and information on how to apply for Davies Award. Again, Jill, thank you so much.
Thank you.